Greetings, listeners, and welcome to the Care Table podcast, dedicated to educating and supporting family caregivers of aging loved ones. I'm your host, Amy Huddleston. Through insightful interviews from both industry experts and family caregivers, we aim to provide valuable perspectives and resources. Let's see who we're learning from today. Welcome to today's episode of the Care Table podcast. Before we get started, I want to kindly remind you, please tap the subscribe bell, like an episode, leave a comment, or share with a friend who you feel like could benefit from learning about this. Today, we're going to talk about home health and exactly what that is, how you get access to it, what services are provided. And we are fortunate that we have two people with us today that I've happened to know for a long time from my days at Home Instead. They have an excellent home care agency in the Central Ohio area. So I want to introduce Elizabeth and Tammy here today, and they can both tell you what their roles are at their premier home health agency. So welcome today, my friends.
Hi, thank you.
Tell us what your roles are at your agency.
I am the owner, and I'm also the administrator. So I pretty much oversee the business part of how, everyday day to day. And Tammy is the clinical director, and she's oversees all the clinical and pretty much the meat and potatoes of everything here.
The nurses and the therapists.
So are you a nurse?
Yes.
And how long have you been a nurse?
43 years.
Nice. Okay, so I think you know what you're talking about when we go into this conversation. Okay, so tell us in everyday simple language, what are home health services?
So home health services, it's skilled, and it's skilled nursing, physical therapy, occupational therapy, speech therapy, aid services, and social services. So what we do is we go into the home and provide skilled services for the patient.
And how do you define skilled?
Based off of nurses. Skilled is the nursing, the physical therapy, the occupational therapy, all of that is skilled. If it was non-skilled, it would be just like an aide that doesn't have an STNA. It would just be like someone who's just a caregiver for that person.
Okay, that's a good differentiation. So who do you think that home health services is designed to help?
Honestly, we've seen a wide range of age groups coming to us at this point. Most of the time it was, the elderly people, but there are a lot more younger people. There's pediatrics too. That's a completely different, area that we do not touch, but there's a big need for it. But there's also younger people that are needing assistance with staying at home and taking care of their healthcare needs.
So anyone is disabled. So they could be elderly or just disabled for a short period of time, maybe just after surgery. They plan to go back to work, but they're going to be homebound for a little while. So we go in and help them rehab in their home, and then they go back to work.
Okay.
So we're starting to see a little bit more of that, I think.
Can you explain to us, how is home health different than when you're looking at like private duty or non-medical home care?
So usually private duty, they provide a lot of hours on a daily basis. We are in there intermittently. Usually the nurse is in there an hour, maybe 1 or 2 visits a week. The therapist is in there a couple times a week. Private duty, they provide more assistance with personal care, like bathing, doing things in the home. I think they do light housework, that kind of thing. I think some places even do like some transportation to doctor's appointments or helping pick up groceries, stuff like that. We don't do anything like that. Everything that we do, it'll be taking care of a wound or educating them on disease processes, something like that would be more skilled.
So
requires a skilled nurse.
When the nurse comes in, let's say, like you said, like an hour or 2 a week, what is the nurse typically doing for home health?
So they do an assessment, a head-to-toe assessment, like you would do even if you were at a doctor's office or a hospital. And then they follow up on medications they're taking, any problems they're having. If it's a new diagnosis, maybe a new diabetic, they teach them how to use a glucometer, how to do their sliding scales, how to take their meds, when to follow up with the doctor, when to call us. We can be a liaison between the doctor and the patient, so it kind of helps the patient not to have to go to the doctor all the time,
right?
Or to the emergency room or to a hospital. We can just kind of treat them in their own home.
Which is where most people want to remain. So that is key. And I think you made a really good point to help people understand when you get home health services, it's skilled, but you get the nurse about an hour a week. You get a physical therapist, maybe, 3 visits a week. Maybe you have some occupational therapy,
Right.
but help people understand that if you need more care, let's say you're not eating well, you're not taking your medications on schedule, home health is not going to really address those things.
Correct. We can help address it. We can link them up with resources. But however, so we have, close connections with people who do private duty, but we refer to them because we're not in the home enough to provide that care. And that's not a skilled service by insurance or Medicare.
Right. So, and help people understand what's the difference between how you pay for home health services versus how you pay for private duty.
So home health services is covered by your insurance. Almost a lot of our clients have Medicare, so that's paid at 100%. And then there's also Advantage plans that some of them have copays, some of them don't. It all depends on the type of plan that they have. But home health skilled is covered through their insurance versus private duty is paid privately. So they're paying out of pocket for that service, which a lot of people don't realize. They'll call us a lot like, okay, we want to set this up for our family member, and they think that the insurance is going to cover it, but it doesn't. It's something that they have to pay out of pocket, and most people, it's very expensive. And it's sad to see people saying like, I can't afford it, and I wish there was another way around it, but unfortunately there isn't, and it leaves a lot of people needing help. And I think that's another thing that go into that without them getting the help that they need, then you're seeing the people that are going back and forth to the hospital, going, not saying bothering the doctors, but they're calling the doctor, they're confused, they don't know what to do because they can't afford that extra help, and that kind of puts them in a bind. And that's kind of how healthcare spirals out of control with all of that.
I just interviewed someone that gave me a little bit of hope that Medicare is finally giving home care a seat at the table, and they're starting to consider, covering some home services. And I know you both know me for a long time, where I feel like that's a long time overdue, because I saw over the years, home care really did change lives for people. And especially when you're supplementing it with home health services like you provide, you're able to keep them home longer, because the home health nurse comes in and can make sure the nurse, like, let's say the meds are set up properly and the meds are appropriate for the patient. And then you can have a caregiver come in private duty that's going to make sure they're taking their meds in the morning and at lunch and at dinner, or bedtime, and keeping them on that schedule, making sure they're hydrated, making sure they're eating, all those things that help keep them out of the hospital. But I completely agree with you. If you can't have that supplemental care and you don't have somebody that's helping you stay hydrated, eating well, going to the bathroom where you're not hopefully going to get a UTI, all those things that, could easily send people to the ER, it's very hard to succeed at home. Help people understand with home health services, how long does your care typically last?
It's typically like a 60-day episode. Sometimes it will go longer depending on what's going on. If they have a wound and the wound's not healed, the nurses will stay in. Or some of our knee patients, they'll have a knee replacement, come to us a couple weeks. They're in outpatient because they're back to driving or getting around in town, and they're doing fine. But typically it's about 60 days.
So when you say the driving, is that, help us understand, like, does that mean you can no longer have your services? How does that, help us understand what you need to be your situation at home to qualify?
For home health, they have to be homebound, which doesn't mean you can't go to a doctor's appointment or you can't go to church. You just can't be able to get out in the community, go to bingo every day, because then Medicare says, well, why do you need somebody to come into your home and take care of you? If you can get out in your car, you can drive, you're safe to do all that. So they have to be homebound, only to be able to go out for medical appointments.
So medical appointments and church, which is funny.
Church, they can go to church. Yeah, they can do things like that. Once in a while, we have a patient that wants to go get their hair done or something like that. But that's mental health. So
I agree.
We let them go. And now if somebody takes them, they can't drive. That's totally different. And
we have to prove, to Medicare and to the insurance companies that it is it's like a couple. We have to prove like in 3 different ways
That they're homebound.
How they're homebound. It's a taxing effort, and we have to, be specific on that, and the doctor has to sign off on it. It's a very serious thing, because if not, then we're illegally billing insurance for those services that they should be getting outpatient for.
Okay.
Or not at all.
When you are talking about, you just mentioned like a doctor has to sign off on it, what you're proving to Medicare. If I want home health services for my family member, I would say, let's start with first, who do you think is appropriate for home health services? I know that's probably, you could answer a lot of different scenarios, but in thinking about the older population, maybe talk about what do you see the most where our listeners can understand, hey, my person could be appropriate for home health.
So like examples of patients that we have?
Yes.
We see a lot of congestive heart failure patients. They need a lot of follow-up medically by a nurse assessing and medications and getting them, make sure they're doing their weights, that kind of thing. But we see a lot of surgical patients, COPD patients, ortho. We do a lot of ortho.
Like, so kind of the knee replacement,
hip,
shoulder. Okay.
And we're usually, like I say, we're usually only in there a couple, 3-4 weeks, and then they're to outpatient. And again, orthos like for them to go to outpatient right away, but some people don't have caregivers. They can't drive right away. So we kind of have to go back to the ortho and say, hey, that's a great idea. However, they can't drive. They're caregivers. A lot of us are caregivers now, and we're still working. So working full time and trying to get someone to appointments is near impossible.
It's really, what do you tell the ortho? I think that's interesting. If you're saying they send them home and they make a referral for home health, what do you tell the doctor?
Sometimes they don't.
Yeah.
We just call and say, we know that you want them to go to outpatient, but they're not able to get to outpatient. They can't drive, or their caregiver, their son or daughter, is working full time.
Can't
the
do
hours of all those things are during the day when they work. So we'd like to go in for a couple weeks and help them, have the therapist go in and do their rehab in the home. And typically it's not a problem at all. They usually just say, oh yeah, that's fine.
Okay.
And then we flip them to outpatient as soon as we can. But
and when you say flip them to outpatient, what do you mean by that?
Refer them. We transfer them. Once they're done with us, then we make a referral. We help them get set up with an outpatient.
But explain to a listener, like, what is outpatient? What does that mean?
So outpatient therapy is you would go to a clinic to do your outpatient therapy.
Okay. So you go from you're providing the therapy in the home.
Right.
Instead now, since they can drive.
They will drive to
themselves.
A clinic.
Okay. Okay.
Correct.
So in addition to those typical scenarios where you're saying, orthopedic surgeries or COPD, what are some other things that you see where home health it could be appropriate? Because I know in working with you over the years, there were, situations where maybe somebody was falling and they were getting unsteady, or they did get a new diagnosis, or they were not thriving as well. So explain some unique situations like that to listeners where it might be like, oh, you know what? Yeah, that's my mom. I should look at home health.
We start seeing a lot of patients when families will call us and say, gosh, mom just had a doctor's appointment. I do see that she's declining. She's not as strong as she used to be. She's not getting up and down from a chair like she used to. She's having trouble get to the bathroom. That's that's usually a number one goal for caregivers and family, patients, that they want them to be able to get to the bathroom. So our therapists can go in and treat them and try to make them stronger. They do an assessment, so they decide what kind of exercises would be best for them. And the best part is it's in their home. I think a lot of times they go to therapy in a hospital or in a nursing home, which is all great. But then they come home and it's totally different surroundings. So they have to learn how to get around their furniture. They have to learn carpeting, or if they have, tile floors or whatever they have to get around on. So those are always good referral patients for us to get out and see if we can help them get stronger in the home.
I always bring up with the physicians when we're talking to them, who are the ones that are your like problem childs, like, and I don't mean to say it in that way, but to them and their, when a doctor's office, it's who's calling you over and over, confused.
Multiple appointments.
They're the frequent flyer. Yeah.
I'm not sure. Like, I can't remember if I take this medicine and what is it for, and I feel this way, and is this normal? Like, those are the ones that you want us to get in there so that we could, help them feel comfortable in their home with whatever is their new norm,
Yeah.
and help explain things to them and educate them and educate the family so that everyone's on the same page so that there's minimal confusion.
Right.
And sometimes that takes a while. It takes a while to get the patient on board to understand their new norm and the family on board to just all be like to work together instead of, being upset with your mom because she's not remembering or she is not sure. It just there's so many variables, of just being, frustrated as a caregiver. Um, but how we could actually help, help the whole family, not just the patient.
would think that the doctors would really appreciate you addressing that for them. I mean, I'm sure they don't
Mhm.
think about
Yeah.
it that way, but if you ask
Mhm.
them and they say, "Oh yeah, I do have a list that
Mhm.
this would completely be
They
appropriate
do.
for,"
Mhm.
where because I mean, I think you agree with me that most people want to stay at home,
Right. Oh, absolutely.
right? The percentage is, I mean, probably in the 80% or higher of people want to remain in their home. So if there's a way
Right.
that you can help them do that safely,
Mhm.
it's a win for everybody. So
Right.
I think that's great. Are there any other situations where people that could be listening could say, I think they're not as strong, they're having trouble getting up, um, a little unclear on their medications. Anything else that you would say would be a reason to ask your doctor for a home health referral?
And we also have speech therapy, so they look at some dementia things too with cognition, swallowing changes with later stages of dementia, and so our speech therapist can go in and help with different techniques for that too. So that's
That's
another
great.
reason, another kind of patient that we see.
Can you get
Occupational therapy, we do shoulders too, so occupational therapy can work on
okay?
shoulder surgeries too.
Explain to what like I mean, I know obviously a PT, most people understand a physical therapist. They're going to help you physically with exercises,
Hmm.
but give us an idea of what does an occupational therapist do and what does a speech therapist do?
So, an occupational therapist, if you think of it as, I always think of physical therapy as mostly lower body, but they do some shoulder and upper body also. But occupational therapy is typically your activities of daily living. So, your bathing, your fine motor skills, eating, those kind of things.
Okay.
Speech therapy will work on cognition, memory, swallowing techniques. Even she goes in a lot and looks at sometimes people come out of the hospital on a pureed diet and the family will say they've never ate this pureed diet before, we want them to eat regular, so she'll go in and see if they're safe to make their diet regular or maybe not pureed but maybe just soft foods. So that's a really nice thing that she can do and help
That's a
families with.
I I would love for people to really understand though, if you get discharged with a puree diet, there is a reason, people. Like,
Mhm.
Correct.
right?
Correct.
And so that I mean, help us understand why that's the
Hmm.
case. Why is that the
Well,
case?
that's correct because sometimes that's all they can swallow safely and after they've had a stroke or something. But as they improve, if speech therapy works with them and they get their muscles stronger and they can swallow, that their swallowing improves, then they can um, go from pureed diet to maybe a mechanical soft diet, or finger foods or so that's kind of a nice thing. As you improve in the home, she can tell you this is the kind of foods now you can go to. These are safe, these are not safe.
Yeah.
So it's kind of a nice thing and it doesn't cost anything extra. She can do it all right there in the home. And she was talking, just to go off what Liz said, insurances, some of them do have copays, but I would say probably 90% of them pay 100%.
Mhm.
We very seldomly really come up with anybody that has a copay.
Help people understand, I can't like, what happens if I just called your agency and said, "I would like some home health services for my father-in-law." How does that work?
Mhm.
So if somebody calls, we will get all their information. But we do the one thing that a lot of people don't understand is that you have to have a doctor. You have to have seen the doctor because we have to have that face to face. And without that face to face, which is a no, you have to see the face to face means you have to see the physician. The physician has to sign off and give you the actual visit note, and it has to be related as to why we're skilling the patient for home care. So that's the biggest thing that we have to explain to people for them to understand. But most of the time, it ends up working out. And once we get the face to face, once they see the doctor, then we're able to get the order and start services. But as long as we have the face-to-face note, that's the biggest hurdle, because some people haven't seen a doctor in years, or don't even have a doctor. So then we have to call. We have physicians that will help us get patients in, because some doctors don't even take new patients because they're so busy. So then we call our doctor and say, hey, can you take this patient for us? And they will. Or we have another company that will go there and see the patient at home, because some of them can't leave the home to go see their physician.
Right.
So, and we're seeing a lot more of that, where they're not able to leave the home. Like, it's just not possible.
Wow. So are you using like a what are those doctor services that just go to the home?
Like a mobile traveling physician.
Okay.
They'll go out.
So that's getting more popular.
Most definitely. A lot of people go to the hospital and they'll come out, and the case manager will say they have seen Dr. So-and-so. They said that's their doctor. And then we call that doctor and they'll say, oh, I haven't seen that patient in 6 years. Well, they're not going to follow, obviously, if they have not seen you in that many years. So they'll either agree that they can get an appointment and come in for the face-to-face, or if they can't, then we'll help them try to get a mobile physician in.
Do you think that most home care agencies will help the patient like that, like you're doing?
Mm-hmm.
I don't know, but I would hope so.
You would hope so, because I'm saying if you want the services.
Because
but we've seen and heard a lot of stories of,
right.
the lack of initiative that some agencies don't take to help. And, we've gotten several patients that, have been with companies that just, they don't go the extra step to help them, and explain things to them. And to me, I think that's what sets us apart from a lot of agencies, is that we care. We really do. We want them to be successful, and we want to help them.
You want them to thrive at home. And so you're going to figure out what to do. So to clarify, make sure people understand, you can't just call and get home health services. You must see a physician, where the physician is basically assessing you and saying, yes, you are appropriate for home health services. Then they sign an order. It gets sent to the home care agency, and the home care agency starts services. Roughly, how soon do you start services when you receive a referral?
Within 48 hours, as long as the patient's in agreement.
Wow.
We'll get out there.
So, okay, that is interesting what you just said. What do you mean, as long as the patient is in agreement?
Well, sometimes we get a referral and we'll call the patient, and the patient will say, well, I have an appointment tomorrow and I have an appointment. Well, it's the weekend or it's a holiday. Can you just come next Tuesday? And we have to go along their wishes. We, of course, can't go into their home without them agreeing. But if they have a wound or they just got out of the hospital, we try to encourage them to really let us get in there.
Quickly.
The quicker we can get in, the quicker we can prevent them from going back to the hospital.
So that's
which is hard, for an elderly person to let a stranger into their home,
especially today.
I mean, it's scary, so they're dreading it, and we get it. So our job is to make them feel as comfortable as possible, as far even from the beginning of intake. Our intake person has to be, sincere and understanding, and just try to talk them through, what the process looks like, so that they feel comfortable. And sometimes it takes a few tries, and that's okay, because they're building a rapport with them, and they're starting to trust, just listening to, just talking to them. And then finally, like, okay, or, they're like, oh, we don't want anyone right now. And then maybe they had a fall or another decline, and they're like, we don't want to go back to the hospital. So like, this is why we need to be in here, but sometimes it takes a few tries.
My word. I'm like, so what's your words of encouragement to family caregivers about home health services?
Patience.
Yeah.
Not patience that ends with TS. Patience that ends with TE.
Patience.
Right.
And what do you
mean by that? Talk our loved ones into it is, it gets difficult, but we just say, just let us come and do an assessment. If you change your mind, it's fine. And typically, our staff is so great. Like, they can, typically explain to the patient once they get there, and they kind of bond with the patient. Once you start talking to them and they trust that you're going to come in and, oh, they are okay. Oh, they are in a uniform. Oh, they have a badge on. Oh, they're okay. They're going to come in and take care of me. Typically, it works fine, but you just got to get through that first little hurdle of letting them come in.
Home care was the same.
Yeah.
Yeah, but home care was the same. I mean, and home care was even more challenging because you're staying longer
Long
in the
periods.
home. At least you're doing shorter visits where you can
Right.
kind of say, I'm just going to be in and out. We're just going to we're going to do a few things here, but it's always a challenge. And I get it. I mean, nobody wants to say I need help and
Right.
or I
Right.
can't do what I used to do on my own. But for home health services, I feel like, there's an end date because you were saying like typically it lasts about 60 days, could last longer. When you say that it could last longer, how is there another home like assessment that needs to be done by a
Mhm.
physician? How does that work?
We have to do a recertification. So we have to go in and notify the physician of what's going on and what we're still working on. We still have to have goals. They have to meet their goals. We set goals from day one, and they have to meet those goals as we're going or improving or a new goal comes up. So we're constantly addressing something with the patient all the time. And then at that recertification, if there's more to work on, we ask the doctor if we can continue, and this is what we're working on, and this is the goal. And typically they say yes, that's fine, and we continue. Now,
What
obviously, if they have a wound or something and it's not healed, we're not going to get out. We're going to stay in there till it's healed. So
what is it that when you say let's say that 60 days wraps up, explain to people what you were talking about when you have those goals. Why do you have the goals? And why do home health services end?
so we have to set goals for the patient to show why we're skilling them. There has to be reasons, medical reasons, why we're skilling. Why I have to prove why they require a skilled nurse or a physical therapist or an occupational therapist. So that's the goals between the doctor, the nurse, therapist, and the patient. And then we work to continue to meet those goals. And then whenever they meet those goals, so for instance, if it is a knee that's only going to be a knee replacement that we only have for a couple weeks, they're going to meet the goal of, they can walk, they can get to the car, they can get in and out of the car. Now they can drive, they're off their pain medications. So once they meet that goal, then we would discharge. And that's all in preparation. We have to give 48 hours notice before we discharge. And we're planning that discharge again from day one. So they know about when they're going to discharge. Very few stay on longer than 60 days or, 2 episodes. We call them episodes. So.
And would you say those goals are the requirement of Medicare?
Yeah, you have to prove what you're doing in the home. So
that's why. So it's helping people understand like it's really a Medicare requirement to say,
correct.
Doctor has assessed them. Here's the goals that are set. We're going to help you meet those goals. But as soon as they're met, Medicare says, we're done.
Right.
Okay.
Right.
So I wanted people to understand that. So,
and Medicare reviews all those records.
Right.
So we have to send everything in and show and prove why we're in there. And they can say, okay, there's not enough documentation to prove why the nurse is in there or why you need this many visits for therapy. So we are all of our therapists, all of our staff, they're very well educated on how to document, to be able to prove to stay into the home.
I'm sure that that's not easy. And how often are you hearing from, like, is it daily that you hear from?
Yeah.
Wow. Okay. Are there any instances where I could pay privately for home health services?
So we do have several patients that pay privately for nursing. So the families say we discharge a patient from skilled services and the family still wants our nurse to continue on, whether it's just for a nurse checkup or for medication setup. So we do have several that pay for that weekly.
And is it still just like once a week, an hour visit, like typical? Okay. And do all home health agencies offer private pay nursing?
I'm not sure.
I'm not sure if they do or not.
So you'd have to ask.
Yeah.
Okay.
Yeah.
So it's like, I just was curious
I
because
would say probably not. But I guess it all depends on how it's structured, how their business is structured. But we just saw a need for it. We don't do it. We don't market it. We just offer it to our patients that are discharging.
I think it's anything that helps them not go back to the hospital, which is what they don't want to do.
And family members are nervous. They don't want. They're not clinical,
right?
And they don't want to pretend like they're clinical. So they just feel very comfortable. Once we have a relationship with them, our nurses are great. The patients are asking, the families are asking, like, we don't want her to leave yet. We still want to keep her on. So we just stay on.
I think
Mostly
it's
for
fantastic.
medications. Yeah, I feel like it's medications. Families don't feel comfortable setting up medications, or when they get new medications, making sure it's set up correctly and they're taking them. It's one of the number one reasons people go back to the hospital is they're not taking their medications correctly, or they're not taking them at all, or they didn't get them refilled, or there's multiple reasons. But
I think that's a big thing for people to understand too. When you have a private caregiver versus a home health agency, in most states, a private caregiver is not permitted to set up med boxes, period.
right.
It does need to be like an LPN, RN, which is why you're looking at home health services. Are there also instances where families say to you, I want to continue my physical therapy or speech therapy and I want to pay privately, even though you're being discharged from Medicare?
Yep.
And you allow that too? Well, that's wonderful. Okay. Again, you're helping people stay at home. That's where they want to be. So if they're willing to do it and they say, I have the funds to do it, I think it's great. And it sounds like wherever area you're in, you would need to call that home health agency or wherever you're getting services to say, do you offer private pay?
Right.
Okay. Are there, let's see here. We already talked about like the typical episode, how long that they last, and how to get those services extended. Tell us about how you feel home health helps not just the patient, but the caregiver.
It helps the caregiver feel confident in what they're doing. So at least they have another set of eyes and ears over them, especially from the clinical aspect. Because again, a lot of people just aren't, they don't have that. They're not a nurse. It's hard for people to figure that part out. And it's especially when you're dealing with meds and all the amount of meds that some people are on. It's a scary thing. So I think just giving them the confident boost that, okay, that is taken care of. I don't have to worry about that. Then I can worry on just being that caregiver for them above and beyond of what they can do.
Not only that, there's a lot of people who do not have caregivers. So we keep saying caregivers, but
a lot of them don't.
More and more we are finding they have no caregiver, or their caregiver who would be their caregivers live in another state, or they're here to visit for a couple of weeks and they've got to get things set up before they leave to go back home. So it's really nice that we can get in there and meet the patient and that family member before they go out of state. And then we can, like Elizabeth said, be the eyes and ears for them when we're in the home. But more and more we see there are no caregivers at all.
Well, that breaks my heart, but
yeah, it's pretty hard to try to even do skilled services for them because there's nobody to help with wound care or to help with a catheter or to help with anything in the home. So
that's really challenging. And I think too, we've had our family members, when you leave the hospital, I know they're doing their job, but they give you this whole list of instructions and they tell you to do blah, blah, blah. And I just think you didn't hear a word of what they said, right? And they give you this stack of papers and the paper says, follow up with your doctor. And I feel like that's where home health is a massive benefit, where all of a sudden you get someone that can spend a little more time with you and can say, here's what you're supposed to do. And I think that's what families really need to hear is that, let's say you are in a hospital situation, they want to make a referral for home health. Don't turn it down. Because you can easily leave. We've watched our family members leave and I'll say, what did they say about when you can shower? I'm not sure.
Don't know.
Don't know.
Right.
So, it's
where's
little
the paperwork
things.
Over there?
Right. Yeah. There's a stack and they don't want to look through it. But I feel like that's where this home health services fills a huge void for families that can say, I am a skilled person, so I can tell you, you're not going to shower till tomorrow and we're going to do this and don't take that, that bandage off until 2 days from now or whatever. But you can't retain all of that, not when you're in this stressful situation and they've just, you're just more wanting to be okay. And you didn't hear anything they told you to do. So I can see why this is incredibly helpful.
Same thing when they come from a nursing facility. It's the same thing. Like if they refer you to home health, take it because the same thing, they're going to send you home with a bunch of bubble packed medications. And so you have 30 pills in a bubble pack. Nobody ever knows what to do with those. Can I pop them out and set them up? They never know what to do with any of that stuff.
I have seen that too many times to count. And it's like
Mhm.
this big Ziploc bag and it's stuffed with all these
Right.
things with some sheets of paper. And it's like,
Correct.
go figure it out.
Right. And then they get home and they're looking at what they took before, which is already set up and what they're used to. So they end up taking those medications and not following the new medications. We find that a lot. So the nurse is like, wait a minute. You're taking 2 blood sugar meds. You're taking 2 blood pressure meds. So it happens a lot because they revert back to what they know is the norm. So
And then you
we can
just
be a real
start
big
that
help.
cycle again. They go back
Right.
to the
Correct.
hospital. They go
Yep.
back to the facility and think
Yeah.
about what that's costing the system.
Yeah.
Instead, if you were to just to get
Right.
them home with home health and let me get you all situated.
Right.
That, we could talk.
Yeah.
That's a whole nother episode.
We
Right.
bridge the gap.
Yeah,
but if they don't
for
allow
sure.
us in, then then that bridge is no longer there, and then they go right back into the system.
Right back. So it's just they have to, I feel like it should just be required. I mean, even if it was just for 2 weeks, we're just,
Right.
we're
Right.
going to get your meds set up. We're going to make sure you're good to go and
Mhm.
that you can safely get to the bathroom. I mean, all
Yeah.
those little
Right.
things that matter, but it's,
I also think it does matter how the hospitals, how the discharge planners, what their approach is of how they explain it to the families and the patient, because a lot of times I hear like they're just, oh, do you want home health, and they don't explain to them, okay, this is what they can do, and this is why we recommend it, this is why we're you should need to do it, because this is, you want to go back into the system, like it's a high chance, it's a high probability of them going back into the system if they don't have someone to help bridge that gap for them when they return home.
that's why I'm trying to do episodes like this of just, I want families to understand like, what is home health? I mean, I think when you're the discharge planner, it's just easy for you to say that, but it doesn't mean that families understand what it is. They have no idea what's offered to them. So if you even just say that, they don't know what it is. So like you're saying, if you don't take the extra 3 minutes to explain, you'll have a nurse, you'll have a physical therapist, you'll have an aide that can come in a couple times a week, and maybe some speech therapy or OT. But if they don't explain it, why are you going to say yes to it?
Yeah, exactly.
So I'm trying to educate people on these are the things that are available to you, because it especially if Medicare is covering it, use it. You're not even paying for it.
Right.
And I think that's a big fear for a lot of seniors.
How much does this cost? Right.
The cost of it.
How much does this cost? Are you sure my insurance is paying for this?
Again, though, if they took 3 minutes to just say, it will get billed to your insurance, here's the services that would be available, I encourage you to just have an assessment. That's all they need to say, right? Let's just do an assessment. And then do they let you come into the hospital and do like the intake there?
So if we know our patient is there and going to be discharged, then we will send our marketer out there to go meet with the families and just, introduce herself and just say, okay, we're going to be there, just explaining everything to them. But they don't allow people just hanging out and trying to, to talk to families. They're very strict about that.
Why do you think that
I
is?
get it.
And sometimes the discharge, they don't know when it's going to happen.
Right.
Enough time for us to get in there.
Right.
So they might call and say, I think they're going home today, might be Saturday. We don't always know exact dates. So that makes it a little hard.
Don't you think that it would be, like you're saying, the bridge would be more stable if you let people talk to them before they left the hospital? But that's
right.
Yeah. So on our end, like we're trying to track and see, okay, if patients are in the hospital, which hospital are they at? Where are they? What, go visit. And that's a beast in itself to track because, it's a revolving door.
Right.
And so sometimes we don't know. And so we have to track, the patients down, figure out where they are, call the families. Like, I mean, it's a lot, but I think that's what makes us successful.
We do a pretty good job at it. Just keeping track of where they go. Well, that's good
care. That means that you obviously are caring about this patient and what's going to happen. You want them to succeed. You don't want them to go back to the hospital, obviously. So it sounds like what sets you apart from probably other agencies. You talked a little bit ago about some of the misconceptions about home health services. You said people don't understand that you have to see a doctor first to be assessed. I'm trying to remember what else you shared, but what are the misconceptions that you mostly hear in phone calls that you get or in your experience about home health?
I would say a lot of people just think that we're private duty.
There's a cost to
Yeah.
them.
So there's not a cost, to clarify.
Mhm.
Typically, there might be a
Typically,
copay,
right.
but typically
I'd
there's
say
not a
the
cost.
biggest percentage, there's not a cost
Yeah.
at all, not even a copay.
Do you think people think you can stay longer than you typically say?
Yes.
Okay.
They think we can do a lot more than we can do. Meaning, well, I thought, like, after we were already in there, we've even explained how we go in, we're going to be there about an hour. The first assessment's maybe 2 hours. And they'll call sometimes, even though we've explained that, they'll call and say, well, I thought you were going to stay all day, or I thought my mom was going to have somebody sitting with them all day long. Well, that's not the skilled service part. That's where you're going to go to a private duty type of situation. So if you have both, that's ideal, because there is no gap.
Mhm.
But
Right.
I think that's the biggest thing. I'd say cost, and they think we're going to stay longer than we do.
Like for, you're going to be there 8 hours today.
Yes.
And you're
yes.
like, no, the nurse is coming in for an hour, or
Yeah.
the physical therapist usually stays about an hour.
Right.
Right. Okay.
And
Any
you have
other?
to participate. You have to be able to participate. So once they teach you, the therapist teaches you your exercise program, at some point, we hope that you're going to do that on your own. So you have to do that on your own days that the therapist isn't there. We're going to teach you how to survive in your own home without us. That's the goal. The goal is to keep you there without us. We want to be there, but eventually you're going to be on your own.
And that's the goal. Yeah, you're right. That's what you're working towards. I think
Right.
that's also a good plug, though, for home care, because if you have an aide or a caregiver in there that comes the days, let's say that home health isn't there, they can't be the physical therapist, but they can get that sheet of exercises out and say, let's do these together. I'll do it next to you, and make sure that they're doing them, which I feel like you have to see a higher success rate in people
Mhm.
when you've got someone
Absolutely.
motivating them to do it
Motivated.
versus them
Mhm.
doing it on their own. I mean, I think that's all of us, right?
Yep.
Yeah.
Correct.
If you're going to meet me at an exercise class, I'll do it. But doing it by myself, eh,
Yeah. You're right.
right? Any other misconceptions you would say of what you hear with people calling?
Mhm. Some people don't realize that we come to their house. Sometimes they call in and I think that they're going to the outpatient therapy.
Oh,
So with home health, we come to you. You don't have to go anywhere. And I think sometimes that's a misconception, but
and they're happy about that, I would guess,
absolutely,
Mhm.
usually yes.
because that's such a challenge. Okay. I would ask you any practical tips that you would give caregivers right now who are trying to decide whether home health is right or not for their aging person. Like just kind of assessing, looking at them and saying, should we do this or not? What would you say?
Well, I think if you think there's a change in your loved one, you know better than we do. Like if there's a change or you just see something different, call us. We don't have to come out. It don't cost anything to call us. All of us here know who to get you to or how to explain how home health work, or if they would even be a candidate for home health. We pretty much can judge that over the phone. So I say just call us.
Mhm.
That would be the easiest. And we'll direct you. If we can't answer or we don't know, we'll direct you to someone. We have lots of resources.
And that's what we tell. I mean, we have people calling all the time and just saying,
Mhm.
"This is what's happening. What do you suggest?" And we're just listening to them and giving them suggestions, and we encourage them. Like, we're here. If you're going to come up with some
Right.
more questions, and please feel free to call us because this is what we do. We
That's so
we see
kind.
this every day, but we will help you through it. Even if we can't, if we can't take care of your loved one, we'll direct you in the right direction.
Right.
But when you're starting to like question, like, oh, there's some changes,
Mhm.
we're just not sure we can handle this, like just call.
Mhm.
It doesn't hurt. You're right. It doesn't cost
Right.
anything. It's just like,
Mhm.
so if you're not, I know you're servicing Central Ohio, but let's say somebody's listening that's not in the state. How do you recommend that people find a good, reputable, caring home health agency like yours in their community?
Word of mouth is,
Yeah.
talk to others, talk to your physicians. They probably have special, home health, or hate to say a list of who they work with.
And read reviews.
Right.
I would
Review.
read reviews. think that's
there's
a huge
Google
thing.
reviews. There's Home Health Compare. There's most, I would think, most cities now have a aging program of some sort or a community senior program that they could call also. They usually have a lot of resources for them.
To ask, what is this home health compare you mentioned?
So Home Health Compare compares all home health agencies in quality of care, and there's actually interviews or surveys from past patients on there. So you can actually see what patients are writing about your company.
Is that a Medicare website?
It is. It's under medicare.gov.
Okay, so it's the same thing as if you're looking for a skilled nursing facility.
Correct.
They're rated. Okay.
Correct.
That's helpful. I didn't know that existed, but I agree with you that I think the best resource is word of mouth when you can ask around and say, who did you have success with? And
Right.
I also like the Google reviews too, because I feel like I don't know, what are your thoughts on the Medicare.gov site? I feel like you don't always get same thing for skilled nursing facilities. I feel like when I look at those ratings, I feel really bad for these facilities because you're mostly going to get the unhappy people that are speaking up more than the really happy ones. So what are your thoughts on that?
I think just from a clinical standpoint, the quality measure is your outcomes. We're not going to cure everyone. So
That's harder.
I always tell my staff, we're not a 5-star. We'll probably never be a 5-star because we don't lie. I'm going to tell the truth. There are people we just can't cure.
Yeah.
And you have to answer certain questions to get into that quality measures answer. So basically, you're healing every single aspect of that patient to be a 5-star. Well, that's great. I wish
Good
we
luck.
could do that. Yeah, I can't do that. I wish I could. However, I think what they do right in the comments, the survey part, the satisfaction part, I think is important because people who like you will write nice messages in there.
Okay.
Google review, I think I have mixed emotions about that because I work with a senior population. So a lot of them don't even have computers. They don't even know what Google is. They can't even work their phones.
Right.
They're still learning. This is all new technology for them. So I think Google review is great for if you have a caregiver that's, say, all of our age. But for a senior to get on and do a Google review is kind of hard.
It's probably not, yeah. It's a Google review is more the family member or caregiver.
But it's an interesting point you just said is that you're getting more clients who don't even have a caregiver.
Correct.
So you're right if you're not getting those. But I like what I'll be sure in the podcast show notes to include the link to the Home Health Compare.
Yeah.
And
because that's a handwritten, like they have to write, a lot of them write what they think or so I think it would be interesting for people to read that.
And I think for people to keep in mind, like you had mentioned earlier, you have to be willing to work with me. That's part of the challenge. You know, you can't make people do their exercises when you're not there.
Right.
You can't. So people have to understand that it doesn't mean it's a bad agency if, someone doesn't review it great, because you have to also understand that they're just as responsible for their own health. And you can only do so much. And so I think that's what's hard is when you're in there such a short amount of time and you're providing great services, it's still really hard when you think about there's 23 other hours of the day that you aren't there, that you're hoping, right? They're taking a drink and they're walking around the house and they're doing what they're supposed to do. So it's just, keep that in mind is what I would say to listeners is you got to be willing to work with me is a really good point. Is there any other information you'd share about home health for people?
I think we covered a lot of, the important pieces, just being patient and loving and open to your loved one, when they're starting to change, and reaching out for help. I think that's the biggest thing.
First step.
We talk to a lot of families that are just frustrated and you can tell like they're just annoyed. They, and it, for us to see that on that, we see that a lot. So we try to be encouraging and just try to, that's when, like it's time to get some help and, and relieve, the family member of, being a caregiver and letting that family member be a family member versus, the caregiver.
Trying to be a nurse and a doctor. And
all the time. It's not easy. It's not easy.
Yeah. Transportation. I'm the Uber driver. I I agree with you. I think there's a couple things I would add is you and I am sure are both on the same page that we know most people want to stay at home. And I really would love to encourage families that I think, like you're saying, you talk to caregivers, they get really frustrated. And I think a lot of times they're just like, I want to move mom. That's it. I'm moving her into a facility. And when mom doesn't want to move into the facility, that doesn't typically go well. So what I would say is, my piece of advice is I strongly encourage you to take advantage of all the resources that are available to keep them at home for as long as you can, and at least try that route, because you might be pleasantly surprised that it works, versus if you were to move someone who doesn't want to move. And that,
Right.
is,
Mhm.
you have to think about, would you want to do that? When you're in that situation,
Right.
and try to be mindful of that. But there are a lot of home services that can really do a very successful job of keeping someone at home, helping them thrive as long as they're willing. So I strongly encourage families to do that. The other thing I didn't point out is, if somebody is in a facility, do you provide services in a facility like assisted living?
We do assisted living, but not a skilled nursing facility.
Okay, and help people understand why you can't do skilled, but why you can do assisted.
So assisted living is private pay, so we're not double
service.
billing,
Yeah.
double dipping. We're billing Medicare for services that we can provide that the assisted living cannot. So
Okay.
most assisted livings don't do physical therapy, or they have nurses in the building. So typically I don't do a lot of nursing in the assisted livings, but we do physical therapy and occupational therapy or speech.
But that's
We'll
good
go-
for families
We'll,
to know.
we'll go into assisted livings if there's wounds or
Mhm.
catheter care,
Okay.
but most of the time for nursing,
Right.
that's about it.
So it's still an option for families to do home health services in an assisted living, so that they know that it's a good supplemental service for
Mhm.
for helping their person, so that they don't possibly have to go to skilled.
Right.
I mean,
Yes.
that's your goal. So, okay. So this was great. I appreciate you both. For those just listening, Elizabeth has Lady Boss hanging behind her because she is a lady boss. And I really appreciate you both. You did a great job just educating us on what home health is. And I hope that people can learn from this. They'll encourage to reach out to a great local agency like Premier Home Health in Central Ohio. And I just appreciate you both. It's so good to see you.
You too.
Thank you. You
Thank
too.
you.
We miss you.
I miss you. That's a wrap for today's episode of The Care Table. Thank you so much for joining me. If you found this information helpful, would you like, subscribe, write a review, or share this episode with someone that you feel could benefit from hearing this information? I'd sure appreciate it. If you learned of anything during this podcast as far as books, resources, or products that you might think are helpful, be sure to check out the podcast show notes for links to access that information. A friendly reminder that this is not medical or legal advice. This is just information. Consult a professional for your own personal situation. I ask that God would bless you with the wisdom, the courage, and the strength that you need as you're navigating this caregiving journey. And I want to remind you, you are not alone. I appreciate you joining us today. And until next time, stay strong, and I hope to see you at the Care Table.